milligrams. So ladies and gentlemen, I have already told you, earlier the better, lower the better, even lower is even better. And then we'll now take you to the extended study that is called long-term evolocumab in patients with established atherosclerotic cardiovascular disease. What happened here in this, the original drug, parent drug, evolocumab was given, followed up. The placebo arm people, at the end of 12 weeks, they were asked to take evolocumab, and that resulted in reduction of events. The mean LDL cholesterol values here 29 milligrams. People were shifted from the placebo group to the evolocumab group. They were all followed up. People who received later from placebo to evolocumab did not show good. Whereas the people who originally received right from the beginning evolocumab, they have shown benefits with 8.4 years of follow-up. 8.4 years of follow-up. Again, a very, very strong evidence to tell you that the PCSK9 inhibitor evolocumab has shown a maximum benefit, that longer duration of treatment is most important. In patients with atherosclerotic cardiovascular disease, long-term achievement of lower LDL cholesterol levels, even levels less than 20 milligram, has shown the maximum benefit to the lower risk of cardiovascular outcomes with no significant safety outcomes. There is no increase in hemorrhagic stroke, there is no new onset diabetes, only injection site reactions. Rest of the things were all not there, were not encountered at all. So now tell you that earlier the better, lower the better, even lower is even better. The last one is the longer the better, longer the better. So ladies and gentlemen, please remember these four things. 1, earlier the better. 2, lower the better. 3, even lower is even better. And the last one, longer the better. I think that is the message, what I thought I should show you line after line, so that you will get an impression that how important it is to reduce LDL cholesterol to get a maximum benefit for your patients with reduction of atherosclerotic cardiovascular events. In this 4-year trial, it is also seen those people reach the levels of 30 milligram, still they have event rate about 14.4%, thereby showing you need to go away from LDL. What is the one that you should stop now? TG levels. So LDL levels over. Look at TG. Are there evidence? Prominent trial failed to show by using a pimafibrate negative study. Is there a study to say that we can give some drugs to reduce not only triglyceride to some extent, but I get a maximum benefit? Yes, reduce your trial. Which had used icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given for these patients, had shown a benefit of reduction of cardiovascular events to the extent of 25% the primary endpoint, and then to the extent of 26% the secondary endpoints. The ADA today tells you that those people with the diabetes, with one risk factor, those people with the ASCVD, those people in whom you have already reached the LDL cholesterol levels less than 70 milligrams, those are the people who can receive the icosapent ethyl ester for 2 grams in the morning, 2 grams in the evening, to get the maximum reduction of atherosclerotic cardiovascular events beyond LDL cholesterol reduction. That's the message about non-HDL. You should concentrate on non-HDL. It is much more important in people with the diabetes when compared to people without diabetes. There are any number of studies. Odyssey study started showing there is a reduction of non-HDL cholesterol to the extent of 32.5% in those people who received alirocumab. It is a PCSK9 inhibitor. Can we go it? That is the one aspect of the question that I raised was over. Can we decide it as per the risk categories? The ESA guidelines started telling us that it should be high risk people or very high risk people should keep the levels less than 55 milligram. The Lipid Association of India came out with the recommendation of only 50 milligram in this group. There also they mentioned about diabetes, first type 1 diabetes, type 2 diabetes, lesser duration, longer duration, more than 20 years, high risk, less than 10 years, not high risk, moderate risk, like that they divided. I don't want to confuse you by giving all this information. Suffice to say, their recommendation only 55 milligrams, very high risk. But we were recommending 50 milligrams for very high risk people. This is about our recommendation, not a crowded slide, but I will make it simple for you. This is from Lipid Association of India. which had come out with the recommendation that low risk, moderate risk, high risk, very high risk. Low risk, no risk factor or one risk factor. Moderate risk, 2 risk factors. High risk, 3 risk factors. Very high risk, polyvascular disease or people with the recurrent attacks. Extreme risk, polyvascular disease with the recurrent attacks, is familial hypercholesteremia, risk B. So we started reducing it to the levels of 30 milligram. Extreme risk group people, B category, should receive the drugs to get the level of LDL cholesterol down to 30 milligram. So we need to focus not only on LDL levels but also to decide about the risk categories. So find out what is the baseline LDL. Find out how much of reduction of LDL is required. With these two, you arrive at absolute reduction of LDL cholesterol. Find out the baseline risk. What should be the relative risk reduction that is obtained in the studies? Obtain the absolute risk reduction. So you are arriving at one absolute risk reduction, then absolute reduction in LDL cholesterol. Both are required for you to see whether the patient is showing a good response to LDL lowering. So this is the one important slide, what I thought I should show it to you as a slide from Lipid Association of India, divided into 2 groups. One is diabetes without ASCVD, the diabetes with ASCVD. Suppose somebody is diabetic, no zero risk factor or only 1 risk factor, he comes under the category of high risk, in whom you should keep the levels less than 70, 70, 70, not even 100. So people who have target organ damage, more than 2 risk factors, very high risk, keep it less than 50. People in whom have established ASCVD, acute coronary syndrome, diabetes, category A, category B. Category A, bring it down to levels of 50, optional 30. Category B, very high risk, extreme risk, recurrent attacks of stroke, peripheral vascular disease or a polyvascular disease, diabetes with the established atherosclerotic cardiovascular disease, homozygous familial hypercholesterolemia or a heterozygous familial hypercholesterolemia, keep the levels less than 30 milligram. That's the recommendation. The recent drug is inclisiran. I don't want to dwell here because of the time, which is not sufficient for me. Bempedoic acid has come to the market, again an important drug which can be added down to the statins. The last trial, we started a trial with a small number of patients, 122 patients recruited with acute coronary syndrome were all going for a PCI. Those people were taken into consideration for the study. We used high-dose statin, 2 PCS in the ezetimibe. The third drug is a bempedoic acid, or so one is the rosuvastatin 40 milligram, ezetimibe 10 milligram, bempedoic acid 180 milligram, has shown a reduction of LDL cholesterol even at the end of 6 weeks. It is maintained much more. So we are actually thrilled to see these results, which was released by the Lipid Association of India. Most recent, this year 2025, released by the American College of Cardiology. You need to have a good discussion with the patient. Patient interaction is important. Family history, very important. Hypertension, lipids including lipoprotein little a, tobacco use, subclinical atherosclerosis by calcium score, diabetes and its complications need to be taken into consideration. Use any calculator or look at only our algorithm. You identify the patient's risk and then the medical history. If you go by these things, it is possible to treat this patient. Lifestyle modification, statin, non-statin drugs. So ladies and gentlemen, we need to move away from the high dose statin to tolerable doses of statin plus ezetimibe plus PCSK9 inhibitor or bempedoic acid. That should be the strategy. Try to use the available lipid lowering agents to make the LDL cholesterol to come down further to reach the levels as you want in your patient to give him a maximum relief of reduction of cardiovascular event. Thank you very much, ladies and gentlemen, for patient listening.
Sir, for the insightful presentation on treating dyslipidemia and diabetes, because diabetes is a vascular disease and treating dyslipidemia is very crucial. Thank you for the wonderful awareness on treating dyslipidemia, sir. Sir, when you start the PCSK in any case particular instead of statins in your PCSK inhibitors, any special usage in a OPD patient, outpatient?
In those patients in acute coronary syndrome, Don't worry about the LDL cholesterol values. If the patient is having a familial hypercholesterolemia as per the LDL values, there is a strong family history, premature coronary artery disease and death, he is a candidate who is going to get recurrence of events. So levels of LDL cholesterol may be high. You use a high dose statin plus an ezetimibe plus a PCSK9 inhibitor straight away. You should give it. Patient, diabetes, hypertension, smoker, long duration of diabetes with the CKD problem started, patient has developed acute coronary syndrome, never hesitate to use these drugs, including a PCSK9 inhibitor. Familial homozygous hypercholesterolemia, use PCSK9 inhibitor. Heterozygous, no problem at all, there is no coronary artery disease, but there is a family history, try to bring down the cholesterol values, use PCSK9 inhibitor. This morning also I received a message for one of my patients in whom I wanted a LPA. She was asking me what is this LPA. Then I discussed about the LPA. I just told her, she is a very educated lady. This morning I received a message saying that her LPA level is 185. Just like that I took my father for the laboratory test, what he wanted. Incidentally I also wanted my cholesterol level. Surprisingly sir, my cholesterol level is 185. That correlates with the patient's father history. He had aortic valvular stenosis, operated. Number one. He has got a coronary artery disease. Number two. His cholesterol levels are also high. I wanted an LPA. This lady also went and gave the sample. LPA levels were raised. Then indication for PCSK9 inhibitor is to use in that situation where LPA is markedly raised.
Thank you, sir. We invite Dr. Chandrasekhar sir for the stage. Any questions to Dr. Narasimhan sir and Chandrasekhar sir?
Every time I get this question in any meeting, cerviculators are both a PPR alpha and a gamma agonist, number one. It can bring down the blood sugar to some extent, number two. HbA levels probably can come down in a long duration of therapy. It is recommended only for diabetic dyslipidemia. No doubt it brings down the triglyceride levels, but there is no cardiovascular outcome data as on today.